we go along. Hope you can all hear me and you can all see my slides. Well, good afternoon, everyone. Good day. And I wanted just to touch today on pediatric pain management. There's a lot in pediatric pain management, and it's not something we often talk about, but of course, pain's universal. It's a universal symptom that people who are unwell invariably have, and children are no different. It's universal, but it's often neglected. So I think especially in children and especially in young children. But if you understand about analgesia and non-pharmacological management of pain, and you have simple principles to follow and basic drugs, then I think mostly you can keep children under much better pain control and usually very comfortable. So that's what we're going to talk about today. It's a universal problem. It's often neglected. We don't often teach anything about pain management, and but actually it's not that difficult. First of all, you need to understand how to take a pain history. This is really important because often we imagine pain to be just a binary thing, either the child's got pain or not got pain, but you can actually get much more detail and understand the type of pain the child's got, the severity of it, the frequency of it, whether there are associated features, what makes it better, what makes it worse. And so I always go through a standard approach. Probably people who are surgeons would know this better, but I think pediatricians also have to know it. First of all, you should try to identify the location of pain and the location that it's worst. So, that can sometimes mean asking a child to point with one finger to the location in which the pain is worst. Now, of course, sometimes they can't identify down to that level, but at least you should try to identify the location of worst severity of the pain. You should try to understand also if pain radiates, because sometimes the radiation of pain can indicate a different sort of pain. There are ways in which you can semi-objectively understand the severity of pain, both the intensity, often self-reported or using pain scores, which I'll show shortly, and whether the pain is there all the time or if it's intermittent. You need to know something about the duration and the severity trend of over time. Is it getting worse, or is it improving, or is it staying the same? And it's useful to be able to say something about associated features. Does the child have vomiting or nausea or anxiety or tachypnea or palpitations or immobility? And some types of pain, a child will lie completely still with appendicitis, for example. In other types of pain, the child will be writhing in pain because because of the nature of the pain. What makes it worse and what makes it better are important questions to ask. And of course, the younger the child, the harder it is to elicit these more details. But I think we should be good at it and practice it on older children, school-age children, adolescents who have pain, and really try to understand the nature of their pain. And then you can also, to some extent, apply it to smaller children, but it will often mean asking their parents or observing their behaviour, that sort of thing. A lot of the assessment of pain in younger children is observing their behaviour and observing what happens. The WHO defines, in the International Society for Anaesthetists and Pain Management, defines acute and chronic pain. Now, mostly these are adult definitions of acute and chronic pain, and they define acute pain as that which has a duration less than 3 months, whereas chronic pain is longer than 3 months. And the usually chronic pain is different to sort of an acute illness that leads to some pain that gets better. It's usually due to some persistence of a condition. And chronic pain has a lot of other ancillary features. Often there will be the child or the person in chronic pain will often be in significant emotional distress. They'll have often significant functional disability that leads them to be unable to do the daily life activities, whatever they are for the person's age. And also chronic pain tends to be multifactorial. It has a biological basis, whatever the organic injury is, but then there's other overlying psychological and social factors that either contribute to the pain syndrome, or they could make the person more resilient to the pain, the biological pain that they feel. So it's not always that there's biological or social factors that cause the pain to be worse, but actually sometimes certain psychological and social aspects of a patient can help them deal with the pain. So it can go both ways. Of course, acute pain can have emotional distress and functional disability too, but they're obviously not as longer standing. And the sorts of chronic pain that we're talking about are pain related to, nerve root compression, or pain related to cancer, or pain related to other major organ dysfunction that leads to sort of chronic pain that hasn't resolved. So WHO also has this very helpful pain and analgesic ladder, and it's helpful because it divides pain into mild, moderate, and severe pain, and that's a bit separate to the acute and chronic pain, but you can assess pain as being mild, moderate, or severe. And generally speaking, the first line is simple analgesia. So simple analgesia with paracetamol or with non-steroidal anti-inflammatory agents such as ibuprofen or naproxen or indomethacin or aspirin in analgesic doses. Aspirin, of course, we sometimes give as an anti-inflammatory, which has or an antiplatelet therapy, which often has a lower dose, whereas analgesic doses are a bit higher. Better not to use aspirin in young children with fever, of course, but ibuprofen or naproxen, sometimes indomethacin can be useful. And I'll talk a bit about why we might choose non-steroidal anti-inflammatory drugs for pediatric pain, certain types of pediatric pain. Then as pain is becoming more severe, if it's severe despite paracetamol and or non-steroidal anti-inflammatory drugs, then there are other agents that can be used. And I'm going to talk quite a bit about how to manage with opioids and how to use them, and the rare circumstances under which they're useful. So not commonly useful, but the rare circumstances under which they're useful. And you will probably have heard of morphine, of course, and pethidine, but there's other opioids. You may also have heard of fentanyl and oxycodone. They're all opioids that have different durations of action, that some can be given orally, some are given intravenously, some are given intramuscularly. And I'll talk a bit about opioids, but mostly about the rare circumstances under which they're actually useful. Mostly for most pain, mild and moderate pain, we can get by with non-pharmacological therapies, with paracetamol and non-steroidal anti-inflammatory drugs. For some other forms of pain, such as acute post-operative pain or acute pain related to trauma or injury, then some other agents are sometimes useful. And ketamine is one of those agents. And it depends on the dose you use, but low-dose ketamine can give you good analgesia. And it's usually given in conjunction with lower dose opioids for severe post-operative pain or severe pain related to injury or trauma. And that can be useful. I'll talk a bit more about the role of ketamine. And then there's two other agents, lignocaine, which you know as a local anesthetic. We often use lignocaine into soft tissues or into skin to anesthetize the area. Can also be given intravenously. And as you know, it has a cardiostabilizing effect, but it also has an analgesic effect. It's really only useful for neuropathic pain, as is an agent called gabapentin, which is also available increasingly available, I would say, but gabapentin is increasingly available. Ketamine is relatively widely available. But again, this is for very specific types of pain. And these drugs, anything above non-steroidal anti-inflammatory drugs, are rarely necessary and only for specific sorts of pain. There are several principles for the correct use of all analgesics, and the first one is that usually the oral form of medication is better whenever possible. And that goes for acute and chronic pain. It's much better to be using oral medications that are properly titratable, and rather than avoid complications from intravenous analgesia. Analgesia generally for all but acute pain that's going to be very transient should be given at regular intervals. It's okay to have a PRN order for analgesia, but that means that the patient has to actually get pain before they can get the analgesic. That is a PRN basis. If the pain is predictable, post-operative pain, for example, then it's what happens if you wait for the patient to get pain is that they need a higher dose of the analgesic to actually relieve the pain. So it's actually better to be giving it at regular intervals until the pain has subsided, rather than to wait for the child to get pain and then give them some analgesics, because it won't work as well. They'll already be emotionally distressed and upset from the pain, and then they won't get, well, they'll take longer to get some relief. You should ideally give analgesia based on an assessment of the pain severity. And there are ways, as I said, of doing that. It shouldn't just be on the perception that the child will be in pain, but an assessment of pain severity and the likelihood that pain will occur. You should tailor the medication to the individual patient. And there are some people who react more to some medications than to others. That's particularly of the higher order analgesics such as opioids and ketamine, for example. And you should pay attention to detail when prescribing analgesia, and that means checking the doses always, and checking the doses and the dose interval always, and making sure that you've got that right. They're the principles. The oral form, give it at regular intervals, not so much on a PRN basis. Make an assessment of pain severity, tailor the medications to the individual patient, and apply attention to detail, and make sure that staff who are administering the medication know exactly how much to give. These are the sorts of pain scores for children, older children over the age of 3, and they can, when looking at these faces, they can often point to the one that indicates how they're feeling. And so they might be feeling happy with no pain at all, or it hurts a bit with a quizzical face, or it hurts a bit more, or it hurts even more, or it hurts a lot, a pain score of 8. So these are called the Wong and Baker faces, and these are, I think, quite useful for children over the age of 3 you can have this printed out, and children can point to it if they've got pain. The other way is to just assess their physiology, their behavior. Ask them yourself whether they've got pain, and how bad is it? Usually children over the age of 5 can describe their pain in words or numbers, on a pain scale of 1 to 10, for example. Older children can do that. Or you can just ask the child to quantify the severity of pain in their own words, like they've got no pain, or they've got a little or some pain, or medium pain, or it's very bad. So you should try to assess the severity of their pain. Sometimes older children can understand a number to assign their pain, from 0 being no pain to 10 being the worst pain they've ever felt, and they can give you an indication of what their pain score is at the moment. And especially school-age children, if they practiced it, if they practiced it a couple of times, then they tend to get quite good at telling you when they've got pain. And the other question to ask children is, is it okay? Can the child cope with it or not? Because I guess not all pain needs pharmacological analgesia. There are some other ways to manage a lot of pain that doesn't involve drugs. So don't be scared of giving paracetamol or non-steroidal anti-inflammatory drugs to children, generally speaking, but there's also a role for thinking about what else the child can do to address their pain. When we do an assessment of pain severity in all children, but from very young to older, you can also assess the physiological effects of pain. And, children in moderate or severe pain will almost always be tachycardic. They'll often be tachypneic. They may be hypertensive. So measuring blood pressure is very important in children who've got pain. Sometimes they'll be diaphoretic, they'll be sweating. And sometimes in younger children, they may even have breath holding episodes if they're in significant pain. Their activity can vary depending on the type of pain. And as I said, it sometimes can be agitation and a heightened level of activity. And sometimes it could be immobility because every time they move, it makes the pain worse, such as I said, with appendicitis. Whereas other children with other forms of abdominal pain, like renal colic, will be writhing around the bed and not being able to lie still. You can ask the parent or the caregiver for their assessment of pain. Is it worse than yesterday or better than yesterday? And of course, as health workers, nurses and doctors, we can make our own assessment of the severity of the pain. But you can use a range of techniques to try to assess the severity of a child's pain. There are, as I said, using the WHO and pain and analgesia ladder, then you can think about what constitutes mild pain or moderate pain or severe pain. I just want to go through some different types of pain and typically what medications are useful for them. And so if a child's got simple pain, they've got a sore throat from pharyngitis or a viral infection, or they've had a minor injury, then usually, almost always, paracetamol and non-steroidal anti-inflammatory drugs are all that's necessary. Even simple pain from minor surgery, often paracetamol, non-steroidal anti-inflammatory drugs, some good local anesthetic, and that's all they need. For severe acute pain, such as a severe fracture, trauma, or abdominal surgery, then you still use paracetamol, unless there's a contraindication. Using some morphine is a good idea for the first 48 hours. And ketamine also has a role. As I said, if you use it at low doses, then ketamine, morphine, and paracetamol together can make a patient, even in severe pain from, say, multi-trauma and fractures or abdominal surgery after appendectomy, that can make the patient pain-free. There are some other pains that are a bit more complex, like I've talked about chronic pain. Well, certainly erosive bone pain from osteomyelitis or a metastatic tumor, then remember, chronic pain requires a different approach, but still non-steroidal anti-inflammatory drugs can be very helpful. They reduce the inflammation of bony erosion and can reduce, especially good with bone pain. There's another medication that's good with bone pain in children with chronic erosive bone pain, and that's dexamethasone. And so sometimes these children are on dexamethasone because they've got, they might have leukemia involving their bone marrow and therefore involving their bones, or they may have some other reason to be on dexamethasone. But that's quite a useful, relatively low dose dexamethasone for a couple of days can be quite useful in reducing chronic erosive bone pain. And I mentioned before neuropathic pain, and neuropathic pain can occur because of any damage to nerves. It can occur because of inflammatory damage to nerves, such as with Guillain-Barré syndrome, or polyneuropathy. And remember that Guillain-Barré syndrome affects both the motor and the sensory nerves, and it's the sensory nerves that, of course, can damage to that can elicit pain. Pott's disease with spinal cord compression or nerve root compression, or osteomyelitis of the vertebral bodies, that can lead to nerve root compression as well. And the sorts of medications that are useful for that, of course, simple analgesia like paracetamol or non-steroidal anti-inflammatory drugs, they can still be useful, a useful base, if you like, for analgesia provision. But there are some other agents that are particularly useful for neuropathic pain, and at various times, depending on the availability of medicines, you might have gabapentin available, which is perhaps one of the better drugs for neuropathic pain, or carbamazepine, the anti-epileptic, or sodium valproate. Sodium valproate is probably a bit better, but there's, not always available. The antidepressant amitriptyline I sometimes use for neuropathic pain in older children and adolescents who may have chronic pain or may have cancer-related pain, and they're feeling also a bit depressed. I find that quite useful. And then, as I said, lignocaine can be useful for neuropathic pain. So start simple and then add one other agent. Don't add them all, but add one other agent, one which is based on the availability of the agent, and the two which is based on which other agent you think is probably the most useful. For chronic pain, neuropathic pain, or chronic erosive bone pain, I very much try to stay away from opioids. The reason for that, opioids are good for acute, severe, traumatic pain, but they're not good for chronic pain. They will lead for chronic pain that's not related to cancer, for which a patient's receiving palliative care, then it's better not to use opioids. But if they have chronic cancer pain and they're under palliative care, then it's fine to use opioids. We'll talk about the role of opioids, but again, start with simple analgesia and then add one more agent depending on what's available and depending on the type of pain. There's some other pain that can occur. So we talked about chronic erosive bone pain. We talked a bit about neuropathic pain, and then muscle spasm itself can lead to a lot of pain, either from trauma or from cerebral palsy with spasticity. Limb spasticity can lead to pain, and for that, using a low dose of a muscle relaxant can help a lot, and that can be diazepam. Again, gabapentin can be useful for muscle spasm pain when you've got chronic muscle spasm, and as can a medicine called baclofen, which leads to muscle relaxation and reducing spasms. I wanted to briefly talk about the mechanisms, the physiological mechanisms for pain. I mean, again, this is something that you could be asked at a part 1 level, but it's useful to know because the basic analgesics have an effect on these physiological mechanisms. And if you think about, if there's trauma to any tissues, then there'll be damage to the cell membranes, and it's damage to cell membranes that leads to a release of arachidonic acid, which is within the membrane phospholipid, and that produces prostaglandins, a whole range of prostaglandins, including thromboxane and prostaglandin, a variety of other prostaglandins. That's through the cyclooxygenase pathway. So if you think there's membrane phospholipid damage that leads to release of arachidonic acids through the cyclooxygenase pathway, leading to the production of a range of different prostaglandins, some of which mediate pain. They mediate pain at a neural level, and they lead to increased sort of excitability of nerves, and that causes pain. Prostaglandins are also inflammatory mediators, and so when you've got inflammation and excitation of somatosensory or sensory nerves, then you can have a pain exacerbation. So just have some idea that that's the pathway for the mediation of pain, and then it helps us understand why the medications that we use have some effect on pain. Paracetamol, for example, is an inhibitor of the cyclooxygenase pathways, and remember that converts the membrane phospholipids, arachidonic acid, to the prostaglandins, and so it inhibits the cyclooxygenase enzymes that do that transformation of arachidonic acid to prostaglandins. It also has some stimulation of a hormone called serotonin, which has two effects. One is it can sometimes relieve our pain and make us more happy, and sometimes it can cause a bit more pain. So there is a biphasic effect of serotonin, which is also a mediator of pain, but also sometimes a mediator of other more positive emotions. There's some other internal mechanisms, including other mediators like nitric oxide, which is found in endothelial cells of blood vessels, and that also has an effect on the perception of pain. And then we also have we all have in our body a cannabinoid receptors. So you've heard of cannabis, but we all, it's a normal process. We have cannabinoid receptors, and we have an endogenous cannabinoid system, which means that there is some effect on that from paracetamol. Important to realize paracetamol is an analgesic. It doesn't have any anti-inflammatory effect. And so if you've got inflammation pain, then sometimes paracetamol in itself won't be sufficient. Non-steroidal anti-inflammatory drugs have both an analgesic and an anti-inflammatory effect. The main toxicity of paracetamol is if it's used in toxic doses. And as you probably know, it can cause irreversible liver failure. Now, that won't happen if you're using it at the standard prescribed doses, but you do need to keep all drugs out of reach of small children, because it's a relatively common complication for children to ingest a toxic dose of paracetamol, and then they can get irreversible liver failure. The same with non-steroidal anti-inflammatory drugs. Children can ingest a toxic dose of non-steroidals and get severe gastrointestinal hemorrhage or kidney failure from it. And so we sometimes think, oh, we have to keep opioids away from children. Well, you have to keep all medications away from children, and that goes for paracetamol and non-steroidal anti-inflammatory drugs just as much as it goes for opioids. The non-steroidal anti-inflammatory drugs also inhibit prostaglandins. They inhibit the arachidonic acid conversion to prostaglandins and prostacyclins and thromboxanes. They were on the lower part of that flowchart I showed you before. So they have a strong effective inhibition of prostaglandin synthesis, and they vary in terms of their duration of action. It does depend on whether their effect is on the cyclooxygenases or on the prostaglandins, and so there is a variety of short-acting prostaglandins, short-acting non-steroidals. And so ibuprofen and indomethacin and aspirin, the types of analgesics we commonly prescribe, they're quite short-acting. They'll give you analgesia for 8 to 12 hours, 4 to 8 hours usually, and then you have to take another dose if you've still got inflammatory-like pain. There are some longer-acting non-steroidal anti-inflammatory drugs. Naproxen lasts about 24 hours. And there's another one called celecoxib, which also lasts for about 24 hours. Naproxen's a bit shorter, maybe 12 hours, but usually we're using ibuprofen or indomethacin, and that's relatively short-acting. Non-steroidals are very good analgesics if you've got pain. So if you've got inflammation as well as pain, and particularly for conditions like rheumatoid arthritis or acute rheumatic fever, where we give aspirin typically, or osteomyelitis, anything where there's inflammation as well as organ or tissue injury, non-steroidals are generally good for. But there are some side effects, and it's very important that we know that. And children, people of all ages, if they're taking non-steroidal anti-inflammatory drugs, they are at some risk of stress ulceration. And the sicker a person is, the more they could get stress ulceration. The things you can do about that are avoid multiple factors that might lead to stress ulceration. So if you're giving non-steroidals, try to make sure you're feeding the child, not keeping them starved. If they're starved, then they don't have anything lining their stomach, and they'll have unopposed acid secretion within their stomach, and that can exacerbate stress ulceration. If you're using dexamethasone, that also increases the risk of stress ulceration. So beware of using dexamethasone and non-steroidal drugs. Non-steroidal anti-inflammatory drugs can also exacerbate asthma in susceptible individuals. So if a child's got asthma, I don't give them non-steroidal anti-inflammatory drugs unless there's a very good reason, because it can exacerbate bronchoconstriction, again, which is prostaglandin dependent bronchodilation. They can also lead to platelet dysfunction. So when you start non-steroidal anti-inflammatory drugs, whether it's aspirin or whether it's ibuprofen, then there will be some dysfunction of platelets. Usually that doesn't cause a major problem, but it can do in some people. For example, if you've already got thrombocytopenia and you add non-steroidals on top of that, then whatever platelets you've got left will be maybe dysfunctional. And for people of all ages, if there's some other risk of kidney injury, such as if they're dehydrated or the patient's got a renal urinary infection, or they've got certainly chronic kidney disease or nephrotic syndrome or some glomerulonephritis, I generally don't give non-steroidal anti-inflammatory drugs because they reduce kidney perfusion. If you've got healthy, robust kidneys, then they should be fine as long as you stick to the right doses. But if your kidneys are sick for whatever reason, then it's best to avoid non-steroidal anti-inflammatory drugs. For many older people who come into hospital and their kidney function's a bit borderline from whatever their problem has been over the years, you add non-steroidals onto that, and they're likely to go into kidney failure. And it sometimes takes a long time for them to get out of that. But we should be mindful of that risk in children as well. So always make an assessment. Is it safe to use this drug, whether it's paracetamol in a child who's got some liver impairment, or paracetamol in a child who's on some other drugs that may be potentially liver toxic, or whether it's non-steroidals in a child who's got who's also on dexamethasone, or non-steroidals in a child who's got asthma, or non-steroidals in a child who's got thrombocytopenia or impaired kidney function. Then we just have to be aware of the interaction between the drug, other drugs, and the patient's underlying conditions. That's all. There's another mediator that I mentioned before, and that's serotonin. And serotonin is it's released from platelets and mast cells after tissue injury, and it has both two opposing, if you like, effects. One is a feeling of pain, so it has what we call a nociceptive effect, and that is, it can cause you to feel pain. And the other one is an analgesic effect. It gives you pain relief. And the effects depend on the site of action and the receptor subtype that's stimulated by the release of serotonin. It's particularly involved in chronic pain, and there are some drugs that can manipulate serotonin, and they're called SSRIs, serotonin release uptake inhibitors. So they have an effect on serotonin. They're often used as an antidepressive agent, but they can also be useful sometimes for an analgesic effect as well. I said I'd talk a bit more about opioids, and again, I hope by now you've realized that opioids should be used for severe acute pain, certain severe acute pains, and some chronic pains, such as chronic cancer pain, but not much else. But certain acute pains, such as post-operative pain, we can use opioids. And the different types of opioids have different routes of administration. And so there is obviously oral morphine, intravenous morphine that can be given either as an intermittent injection, which is not so helpful because it has a fairly short duration, or as a continuous injection, or as a subcutaneous injection, as a continuous subcutaneous injection. It's best, as I said, always, if you can, use the oral agent. Pethidine, for example, is really only available as a intramuscular therapy, and it's not a very good analgesic because you have to have an intramuscular injection to have it. And so I don't use much pethidine these days. Fentanyl is another opioid. It's a synthetic opioid that's used intravenously, or it can be used transdermally. There are fentanyl patches for some people who've got chronic pain, for example, chronic cancer pain. That transdermal absorption of fentanyl can be useful, but again, for very specific sorts of pain. Codeine is another. It's also an opioid, and it's available orally. And there's another drug called oxycodone, which is a rather similar drug. It's available orally and also intravenously as a continuous intravenous infusion. And then there's another drug called tramadol, which I know is available in a lot of private pharmacies. It can be used. It has two effects. One is an opioid effect, but it also has some serotonin effects. And it can be a useful analgesic for moderate to severe acute pain, but it also, all of these opioids, if you take them for more than a week, then you'll have some dependence to them. That doesn't apply to people who've got cancer pain, for whom long-term opioids can be give them great relief. But it certainly applies for non-cancer chronic pain. I try never to use opioids in non-cancer chronic pain. And yeah, there's a few rules about opioid prescribing. As I said, it can be useful for severe acute pain or chronic cancer pain, but it's never an isolated treatment. Always prescribe it with other medications, with paracetamol or non-steroidal anti-inflammatory drugs, and also have a psychosocial model of care. It's not good enough just to give analgesics. There has to be some other non-pharmacological approach to a person's pain. If you're using opioids, you need to properly monitor the effect of the opioids, both on the person's pain and on adverse effects that need to be monitored. I'll talk about the adverse effects. And you should, if ever you start opioids, you should have a plan for tapering or discontinuing the opioids according to the child's condition. And remembering that, if you go longer than 5 days to a week, then you have to have a sort of taper of the opioid, because there may be some dependence that the child has. The family and the child, if they're old enough, should know the plan for how long they're likely to be on it and how long it'll take to get off it. And if a person, for many children that you put on opioids, sometimes their pain may be relieved, but they may feel less sharp in their mind. They may feel a bit fuzzy and in their head, and they may prefer not to be on it than to be on it. So sometimes people can put up with quite a bit of pain if they can have a clear head and a clear mind and be able to function in other ways. I've said before, but it's crucially important to keep all medications out of reach of children. Opioids, because if a child takes an opioid overdose, morphine overdose, then they may have respiratory arrest or cardiac arrest. For the paracetamol and non-steroidals for the other reasons that I mentioned. So, obviously you need to have rules around safety of storage of all analgesics. There are some adverse effects of opioids, and again, if you use the right dose, then very few patients get these adverse effects. But if you need to titrate the dose according to effect. But if you use too higher doses, they can inhibit patients moving because it makes them more sleepy. And in a post-operative period, the right dose is right, and then more than that is, can cause immobility, and that can have other adverse effects like lung atelectasis because the patient is not taking big enough breaths, or they're not moving around, so they accumulate body water, so they may get more edematous, their lungs might get more wet. So you have to be really aware of these sorts of complications. They also, to some extent, inhibit coughing. Codeine, morphine, they all inhibit coughing, which there used to be in many cough remedies, they used to put codeine in cough remedies because it stopped you coughing. Well, it could stop you coughing, but sometimes it's more useful to be able to cough and clear secretions than it is to have retained secretions. And especially after surgery, you may still, a child, a patient, it's better if they can still be able to be pain-free enough that they can cough. All opioids cause constipation, and they all may cause urinary retention. And especially if you're not moving around in the post-operative period and you're on opioids, then you're likely to be constipated. And that can cause a secondary sort of pain. So I always try to make sure patients who are on opioids are also on some laxatives, and we're feeding them, and try to avoid constipation. Now, it's important to realize what opioids are. They're a strong analgesic, but they're not anxiolytic. And so for many people with severe pain, they'll be quite anxious as well. And often, if you use a small dose of a benzodiazepine like diazepam, plus a small dose of opioid, a lower dose of opioid, that's better than a high dose of opioids. If the patient is both anxious and in pain, you have to use the right dose of the opioid because you need to relieve their pain, but you won't relieve their anxiety or their distress. And sometimes a small dose of benzodiazepines. Remember, we're talking about short duration analgesia, not prolonged analgesia. Right. Now I want to talk about non-pharmacological treatments. And what you use depends on the age of the patient. But I wanted to just say, often we don't think too much about analgesia in newborn babies, but newborn babies feel pain too. So if you're putting in an IV cannula in a newborn baby, then that will cause pain. And there are some good ways you can avoid pain in babies, newborn babies, and two ways that I often use. One, wrap them up and cuddle them, and because they prefer that than being unwrapped often. And the other one is with oral sucrose in a syringe. So if you can get some sucrose, 50% glucose, mix it up, just put it in a syringe and just give them a drop on their tongue, a couple of drops on their tongue, and that's often very good analgesia for simple procedures like putting in an IV cannula or anything that you might do to a newborn baby. Is oral sucrose, and wrap and cuddle them, and often you can relieve their pain. For older children, it's really important that we think about non-pharmacological things, and especially for procedural pain. It's important to explain procedures to a child, so you don't just do it suddenly. You explain the procedure. You don't tell them that this won't hurt, because when it does start to hurt a bit, then they won't believe you. But you can say that this will hurt just a little, and we'll give you some medicines to try to help that. You need to speak when I'm doing a procedure, and if a child's awake or doing it with local anesthetic, I try to speak frequently to the child and calmly to the child and try to calm them down as much as possible. Don't escalate their anxiety. For some children that need regular painful procedures, then it's good if they know that they've got some reward after the procedure, whether it's a sip of fluid or they watch some TV or they read a story or they're able to eat after the minor procedure. And usually if you feed a child as soon as possible after a minor procedure, then they often will forget the pain of the procedure. So there's some just approaches. Many children can tolerate some pain, but we shouldn't have children in pain if we can help it with some simple analgesia and by using non-pharmacological methods. In many children, distraction is really helpful. And so using electronic cartoons, I think it's been remarkable to me to see how calm some children can be with watching cartoons. And I've just put here 3 cartoons that I've seen be very useful at different ages. The first one's called Naloya. I think that's very good. And Peppa Pig, of course, many people use. And there's one which is in Arabic called Rafadan Taifa, and that's for older kids. I think that's very useful. They're 3 electronic cartoon videos that you can get on YouTube. These are the YouTube links that have been shown. There's been some studies done. Journal of Pediatric Nursing did a study showing that these 3 cartoons were very good at both distraction during procedures or examinations, and for supplementation of analgesia during procedures. So they can be quite useful. There's some other non-pharmacological things that you can do. When people haven't slept, then they're more likely to experience pain. And so promoting sleep, as hard as it is to do in a hospital, is very important. Music can be good. And I think, you see these days in hospitals, a number of children with headphones on listening to music, and they're listening to their playlist to relax them a bit. I think music can be excellent as a adjunctive therapy, because hospital wards are often very noisy, and there's often other children crying, and that can be distressing for children. So allowing them to listen to music is really important, and trying to promote sleep is also important. I think that even though I said I speak frequently to children, I think you should limit conversations at the bedside that are beyond what the child and family would want to hear. So don't be talking about the child's condition at the bedside if the family and the child wouldn't want to hear those words. Only speak at the bedside in ways that the child and the family could understand, or at least explain what you're saying to the child and the family afterwards. I think it doesn't help pain, but it reduces people's anxiety about the ward round coming around, and about them talking about things that they don't understand. And parents often have, when the ward round comes around, they often think that things are much worse than what they really are because of the way in which doctors are talking. And so it's very important to explain everything to parents and to the child after you've assessed the child. There's some other non-pharmacological things like massage of affected limbs, or for different sorts of pain, heat compresses can be useful, or ice packs, or just repositioning, making sure the child moves their position around. If a child, I've looked after many children who are immobile for a couple of days, and once they start moving again, then often they have pain, even if there's no injury to that limb, just because if we were to lie still or flat for a couple of days, once we start moving again, we'll feel pain. And people don't often distinguish between that pain of just remobilization, from a pain of some sort of injury. And so repositioning a patient, moving their limbs through a full range of movement, can be very useful in preventing pain when the child remobilizes. I think physical activity, doing exercise, walking, sitting in a chair for a short period of time, these are all really important things to help the non-pharmacological approaches to a patient who's got pain. A patient who has pain, who has to lie in bed all day, who only hears doctors talking in medical language around their bedside, they're not likely to have pain relief. But if a child can have some sort of physical activity, get out of the ward, even if it's in a wheelchair, then that can be great for their mental health and therefore for their pain. For some children who are a bit older, then there are other techniques they can learn, such as imagery, like thinking about a happy event or a happy place they had been to. They can help relax the mind. And I think imagery and relaxation techniques can be taught to children, school-age children, and a bit older. Most school-age children can imagine something, that a time that they were quite happy, and that they can go back to that place in their mind, and that can be very helpful. So I guess I've said from all of this that you need to have what we call a biopsychosocial perspective of pain, not just analgesia, but also, you know, the using other techniques that might help them relax, help them be distracted, help them forget about their pain to some extent, to focus on other things, help them to be calmer. And they don't take away the pain, but they can help a child cope with pain a lot better. And it means that the analgesics that you're giving can be much lower doses and not as many. Whereas if you don't do those other things, then you're likely to have to use higher dose analgesics and then get lots of complications from it. Okay. If you don't have a biopsychosocial perspective on pain, then acute pain, and you're using high levels of analgesics, then acute pain can lead to more chronic pain over time. And so I think we have to have this more holistic approach. All right, well, that's all I want to say today. I've talked a bit about the pharmacology and about the mechanisms of pain and how it occurs, and about the medications we use and the non-pharmacological approaches. And I think we haven't previously discussed pediatric pain, so I hope that's been useful too. I'm going to stop the recording now, and I'm happy to answer any questions that you might have.